Thanks so much.
Do we lose the legendary, the one and only? Really? Oh my God. Okay. All right. I guess I'll pick up until she comes back. Or is it? No, yeah, she's not here anymore. Ravi, an intriguing start. And I think you gave us a lot of information. It's amazing if you're sitting in the audience and listening to all of this. It's really hard when you're beginning to know where to begin a story. And how you decide what to begin a story is often influenced by two key variables, which is what is the morbidity of a certain data point and what is its predictive value of what's going on. Charmaine, I can't tell, are you back or?
Sorry, I got kicked out.
Oh, no worries at all. I'll blame it on Rafa because I don't know why. It just seems like a Rafa thing to do.
Oh, it's really funny. Go ahead. I'll jump in.
No, it's all you. I didn't say anything. Nothing. All you, my friend.
I was like, wow, Robbie really wanted to discuss first. Give me out. I'm kidding. So we have a 75-year-old coming in with urinary retention. I think when it comes to urinary retention, especially working with a lot of older men, the population that I see, I always train to think about, the common etiology is BPH. And think about, having a big prostate, that you're also more prone if you have urinary infection on top of that, if you're having medication on board to cause more retention. And the other thing that jumps out here in terms of urinary stent removal about days ago. So anytime the procedure is done, thinking about what could be the complications of that procedure itself. And stricture formation is one to think about. Also pass on so we can layer on other reviews symptoms.
Hello. I don't know if it's me, but you sounded a little choppy, and I'm getting a little bit of, the VA is not paying its internet bill clearly, which is a problem for both you and me. But yeah, no, I think focusing on the urinary retention is a great place to start, and I think using the base rate to tell you that it's probably BPH here, and that's the question. I think is it where is the stent in the urinary tract? Is it in the urethra or is it in the ureter? That'll probably allow you to understand what's going on. And Ravi clarified in the chat that it's a ureteral stent. So not in the urethra, but the ureters. And so that shouldn't be a cause of urinary retention. But I think, my mind is gravitating towards the shaking chills. Shaking chills, i.e. rigors, have a predictive value of bacteremia that is around 70%. So in this instance, the calculus changes to I'm really worried about bacteremia, and the question is, where is it coming from? And where it's coming from has to prioritize recent events, and the recent events are in the urinary tract. So this immediate setup is actually not an uncommon setup, where a patient with urinary proceduralization has evidence of bacteremia. It's not just any bacteremia, it often is gram-negative rods as a result of the LPS, lipoprotein saccharide secretion. For all you step one geniuses out there, one or two things may stick for the rest of your career, and LPS secretion is one of them. But there are actually also a couple of other bugs to keep in mind when patients have complicated urinary tract infections, the most notorious being Candida. So this situation triggers a reflex response, which is blood cultures, antibiotics, consideration of antifungals if the patient has had Candida in the past or has a poorly controlled diabetes. And then you have to make sure there isn't an anatomical issue in the urinary tract resulting in pus under pressure. So those would be my reflex responses to the rest of the data here. Alrighty, Ravi, back to you.
Past medical history, BPH, hypertension, hyperlipidemia, diabetes mellitus type 2, and history of nephrolithiasis. Medications, amlodipine, olmesartan, metformin, atorvastatin, tadalafil, and Percocet. And I'll just type into the chat there some of this so the scribe can keep up. Physical examination, vital signs 39.5, temperature, blood pressure 160/96, respiratory rate 23, heart rate 98, 100% room air, oxygen saturation. General patient was shivering quite a bit, which was noted by the admitting intern. And abdominal exam was distended. There was bowel sounds, and then just jumping to the GU exam, there was no CVA tenderness, but there was suprapubic tenderness and distension. On evaluation of the oral mucosa, moist, patient was perfusing, was warm, and was alert and oriented. Should I stop there, or would you like to have the labs?
I think this is super helpful. I can just take on the background data and then pass the mic to Charmaine to reflect on the exam. And you have two profound pieces of medical history that influence the calculus here. The first is BPH, and patients with BPH are at risk of a couple of urinary complications. The first being urinary retention, with or without superimposed infection. And then the other is the increased risk of prostatic abscesses or prostatitis. So here, you can draw two arrows from BPH to the current circumstances. Not to forget any proceduralization that results from BPH treatment, like transurethral resection and its peri-procedural complications. Diabetes can also affect the kidneys in terms of infections in many ways. All patients with diabetes are high risk of urinary tract infections owing to the hyperglycemia. And then we talked about Candida. So Candida comes into play here in patients with diabetes as a cause of antibiotic refractory infection. But also remember that though not at play here, patients who are prescribed SGLT2 inhibitors in diabetes can get even more urinary tract infections and may even have higher risk for some sinister infections in the perineum, like Fournier's gangrene. So there's a lot of concerning background here. And what it does is it takes the foreground, which is urinary in origin, and puts an exclamation mark next to it. So both the foreground and the background tell you to stare at the urinary tract and know exactly what's going on there, which is something you shouldn't do in real life. It's awkward, but you should do in your head. But it's a great time to also remind yourself, hey, I'm at risk of fixating on this space. Let me glance elsewhere to make sure there's nothing else going on. Alrighty, I'll give the mic to Charmaine.
Thanks, RJ. So today, all of that in mind, I know thinking fever is very high fever, the person shivering, and like concern for well, region usually that I was learning that years ago. I saw a patient sitting in a room writing, and I was like, this that patient didn't have he did but it could have multiple different infections. But I'm thinking of what I'm learning in that online exam. The vision is that we also have like background constipation not to forget about almost like after procedure, someone who has a bit of an opioids that could be that there could be procedures there are anesthesia. So I'm just like keeping track of that as through the case. Sure, there's with also health pathology as well. In terms of pubic tenderness, I use pubic tenderness the bladder itself. In terms of like abdominal pain in general and labors, like it's hard to localize really well. So I would keep.
I'm really sorry. I hate to interrupt you. I think the consensus. Yeah,
okay, you just go for it.
I don't think people can hear. Do you want to try to log off and log on one more time, or?
That's it.
Okay. I feel so bummed. Clearly, we're hearing like poetry and wisdom from Charmaine, but it was very, very hard to make it out. Yeah, I think the summary on this exam is, I think the fever is very, very concerning. A fever this high is compatible with the working hypothesis that there's an invasive infection in the urinary tract. And whenever you have an invasive infection in the urinary tract, you want to prioritize the 2 Ps, pyelonephritis. Well, sorry, I should say the 3 Ps: pyelonephritis, the prostate, and a procedure. So most patients with urinary tract infections, such as cystitis or urethritis or chronic prostatitis, don't have a fever this high. And when you have a fever this high, one of the three P's is happening: pyeloprostatitis, acute prostatitis, or a procedure. And you have to step back and say, okay, does this end with the urinary tract? And here's where you have to pay attention to the constipation and the abdominal distension. Are they signaling that this disease process has extended beyond the urinary tract to include bacteremia or to include maybe a perforation? So I think in this case, you start with RX, you start with antibiotics and supportive therapy, and then you have the lowest possible threshold to do two things you don't usually do in patients with urinary tract infections. One, image to look for complications, and two, to do a digital rectal exam to look for prostatitis. So I'd be doing those two things here. Alrighty, Ravi, back to you.
On to the labs. Just gonna put it in the chat too. That way the scribe can keep up. Okay, sodium 130, potassium 4.3, chloride 96, BUN was 59, creatinine 7.45. And just prior to the procedure a few days ago, a week ago, patient had absolutely normal renal function. Glucose was 275. And then surprisingly, the CBC showed a white count of 6.16 and neutrophil percentage 81.7, hemoglobin 12, and platelet count 288. And then the lactate initially was 2.3 with a follow-up 1.6. And the urine analysis showed clear urine and 1 WBC, 1 RBC, and a few budding yeast, but otherwise unremarkable. And I'll just stop there if you want to comment on the labs.
Oh my gosh. Okay. Ravi, this is so, I can't tell you how important this conversation is. So if you're doing anything else, stop it. This is key. I'll tell you what is most likely, but this is one instance on VMR that I don't think has ever come up before, and it's something you have to think about. And let me break that down. What is likely happening here? You have marked acute kidney injury in somebody with post-renal proceduralization and BPH, and the focus on those post-renal causes is, does this patient have urinary retention causing hydro, causing mass effect? That's one calculus. When somebody is this sick, it's very easy to also invoke the possibility of ATN or acute tubular necrosis and or pre-renal disease. So if you're doing a reflex response of why is this creatinine so high, you'd come to obstructive post-renal causes, one. Two, but that obstructive post-renal could be his BPH, could be the procedural related stunting, or could be his kidney stones bilaterally. It could be ATN, it could be pre-renal. But this is an instance where you have to think about a rare but really important diagnosis. And that is urinary rupture or bladder rupture. Why? We talk about post-renal causes as causes that result in kidney dysfunction as a result of bladder hypertension. Too much pressure in the bladder causes transmission of that pressure into the kidney, causing failure. That's 99% of post-renal causes. Are you with me? Questions about that? Post-renal is a pressure problem. Stones blocking the ureters, BPH blocking the bladder, a clot in the bladder. It's a pressure issue. And if you decompress that pressure with nephrostomy tubes or Foley, problem solved. But there's one kind of post-renal that is the opposite. And that's bladder rupture. So if you rupture your bladder, you have no high pressure in your urinary system. But instead, you leak urine into your belly and you no longer effectively clear urine. So you might as well not have kidneys if you're just going to dump your urine back into your belly. So in a patient who has a procedure, who develops hyperacute kidney injury along with abdominal distension and suprapubic tenderness, an unlikely but no misdiagnosis is a bladder rupture. What does that do? It causes urinary ascites characterized by a high creatinine in the acidic fluid. And it causes what's called pseudo renal failure. It's pseudo because the kidneys are working just fine. It's just that you constantly recycle the toxic products that a patient is trying to excrete but cannot. So this is one cause of AKI without actual kidney dysfunction. The kidneys are working just fine. The problem is the bladder is not excreting the urine into the world, instead giving it back to the kidneys, creating this vicious cycle. So this is a situation that is emergent, that requires imaging and requires urological consultation, because you probably don't want to put a Foley in this patient until you know they haven't ruptured their bladder, because you could end up creating a fistulous connection between the world and the peritoneum or the retroperitoneum, depending on where the bladder ruptured. So this is a very concerning scenario. Antibiotics, fluids, and then probably getting urology on board. This is a rare diagnosis, very rare. Don't get me wrong. Don't conflate the emphasis here with probability. It's not probable, but it changes the outcome so much to know of this. So that's why it's something to keep in the back of your mind. All right, Ravi, back to you.
We'll take it down to the home stretch, or towards the end of the case here. But patient had a bladder scan, which showed about 1,400 mLs of urine. So had a straight cath. Urology saw the patient, and there was a suspicion of urinary obstruction due to post removal of the stents. And so a Foley catheter was placed quite easily. Patient did have a drop in blood pressures and given some volume resuscitation, and then started on fluconazole for possible fungal UTI due to some yeast that was in the urine. But patient continued to be febrile without leukocytosis, which was quite puzzling, but also continued on ciprofloxacin as well as the fluconazole. Procal came back 0.14, and then a bunch of tests were performed. I'm just going to put it in the chat because it might be too much to say. But a CT did show a urachal remnant, mild to moderate left hydronephrosis. There was a 25 stone in the hilum, enlarged prostate. And then surprisingly, going back to what you had mentioned in the beginning, blood cultures then did disclose a organism of interest, yeast. It grew out Candida parapsilosis. It's always a little difficult to say, but so patient was started on mycofungin, and a TTE was started or ordered to rule out infective endocarditis. So just sort of going back, the thought of Candida, which you had markedly sort of indicated in the beginning, everybody was on the bacterial cause initially, and especially when somebody has shaking chills. I've always seen that shaking chills, that's post-procedure, that's gram-negative rod bacteremia, especially with a urological intervention. But I found it quite surprising that Candida grew with this patient who is immunocompetent, not immunocompromised. So also it's a bacteria or a fungus that's not usually grown. We see other sorts though, but I know it's found on the skin and in the GI tract and GU tract. And I guess just with the procedure, this was then moved further up and caused this remarkable infection. Any comments, Ravi?
No, Ravi, I think this is an absolutely superb case. I think there's the common playbook here is this is a gram-negative rod bacteremia in the setting of procedures. But the two diagnoses that you highlighted that abut those things are candidemia and then bladder rupture. Both of those things are worth reading and learning about. And in the case of Candida, I think it's humbling to know that candidiasis is a mucocutaneous disease in most people, limited to the oral mucosa of patients with local issues such as Sjogren's or inhalers for asthma, but usually in their skin folds. But the highway for Candida to get into the blood in otherwise immunocompetent people is the urinary tract. Less commonly, patients with abdominal surgeries can get candidemia, especially if they have to be placed on TPN afterwards. But it's a humble reminder of the immunosuppressive effects of diabetes and of the fungal organisms that diabetes puts patients at risk of. Candida is by far and away the most common. So diabetes per se isn't an immunocompromising condition overwhelmingly so, but there are some organisms that have disproportionate representation with things that we talk about quite a bit, Mucor, Pseudomonas, and Candida too, being higher represented. And I think this, you also illustrated a lot of nuance with treatment of candidemia or Candida infections. It's tricky because you essentially have two options. You have an azole or a fungin. And there's a problem. The azoles are great. The azoles penetrate the urine very well, but don't get into the blood. The fungins get into the blood, but don't penetrate the urine. So it often takes, it's very complicated to figure out how to treat a patient with Candida. So here you were giving an azole, which you might think, oh, this is a good treatment for presumably sensitive Candida in the urine, but it actually won't treat candidemia very well. So even treatment of Candida is very, very complicated. So my advice in real life is when you're faced with a situation to get your ID colleagues on board, they can help you tease through the mess of this. But oh, this is so much, there's bread and butter in here, but clearly a lot of esoteria on the side. So I think this is an amazing case. Thank you so much for presenting it, Ravi.
Especially the white count was normal, but the patient was daftly sick with fevers that were continuing unabated. The procal was normal. So just like you astutely had mentioned initially, right at the get-go, that candidemia should be entertained, and just not candiduria, but candidemia. Even in bacterial, I guess, infections, we just had a patient like this in septic shock from a UTI, and a UTI shouldn't cause this degree of illness, but I mean, spillover of bacteria from the urine into the blood can explain such degree of septicemia.
100%. You know, I will say one final thing for all the mega nerds out there, which is all 36 of us here, and everyone watching later, which is whenever you're dealing with urinary tract infection, your mind should be bacteria. But if you're thinking of a virus, think BK virus. If you're thinking of a fungus, think Candida. And if you're thinking parasite, think schistosomiasis. So there are instances where you have to expand your urinary tract infection spotlight to viral organisms, fungal organisms, and even parasites. So this case is a reminder that when you have a patient with diabetes, you got to think about Candida in the urine. Really, really good case. Ravi, bringing the heat as always. All righty, Vale, the mic is yours, my friend.
Hi, thank you, Ravi, for this case. It was amazing. So some teaching points. Well, the first one, the most important one, ammonium bagillion is not a number, even though I don't know how that's pronounced. But so urinary retention, which was a chief concern of this patient. Oh, sorry, I think, can you hear me or my internet? Oh, okay, perfect. So with urinary retention, we prioritized common presentations such as BPH. But then with the associated symptoms like fever, we thought about superimposed urinary tract infection, also the itis, such as prostatitis. And then with the shaking chills, it was a great clue for bacteremia. So blood cultures could be imperative. And then with the complicated UTI, because of the systemic symptoms, we should rule out anatomical abnormalities, predisposing medications, and also the past medical history of diabetes could make us consider antifungal coverage to cover back candida, like this case. And then Ravi gave us a 3-piece of UTIs with high fever, this grade of high fever, which are prostatitis, pyelonephritis, acute pyelonephritis, and a procedure complicating occasional infection. And then because the patient had also an acute kidney injury, both the procedure that he received, the hyperacute onset of this injury prompted us to think about bladder rupture as a possibility, because also of the suprapubic tenderness and adrenal distension that the patient had. And Ravi taught us that this entity could present with pseudo acute kidney injury, in which the kidneys are functioning, but the bladder is not excreting the waste products, so you will see an increase in the blood exams. And then with the candida infections, that was a final diagnosis, we should think about it in patients who have diabetes, who are immunosuppressed, and also think about what type of candida we are dealing with. So in this case, candida parapsilosis, which is associated with medical procedures and catheters. And we also should look out for candida crusade, which has natural fluconazole resistance. And so in this case, the treatment was the fluconazole for 14 days. So that was it. Thank you so much. It was a wonderful case, Ravi, and an amazing discussion, Ravi.
Ravi, I'm honored that our names sound so much alike that I have no idea what Valida said, which compliment each of us received, which is an honor, the highest honor of all. All right, y'all. See y'all tomorrow. Thank you again.